invite Dr. Faisal. He will be presenting preoperative consideration in a patient planned for trabeculectomy.
So very good afternoon, everybody, and good
Smita,
afternoon,
you
sir.
can join on the dais.
For giving an opportunity to present this talk. So thanks for all my mentors because of them I am standing here. So trabeculectomy means the gold standard procedure. From the beginning itself, 1968, the Keynes has started the procedure. That means we are creating an artificial fistula or artificial passage between the anterior chamber and the subconjunctival tissue. So from that time onwards, there were a lot of modification has been done in the form of antimetabolites and various techniques. Still, the reported long-term success rate is primary tubes range from 57 to 90%. So that means a lot of traps will fail. So the preparation has to be start from the beginning of the patient selection onwards. So I'll be just highlighting some points how you will go ahead to prepare the patient for surgery. So the start from the months or before weeks. So when considering whether, first you think whether the patient require need or surgery or not, and calculate the risk and benefit of the surgery, and this should be discussed with the patients and the patient's caretakers, and especially, and also this is more important if patient is one-eyed. Sometimes trap can have devastating sight loss complications. This should be explained to the patient, and the risk-benefit ratio should be calculated. Of course, the socioeconomic parameters also, because the cost per surgery may not be very much or maybe less costly as compared to your routine cataract surgery, but the follow-up is very highly required in post-trabeculectomy, especially in the immediate post-operative period. Maybe within a month, immediate after one patient may have to come 5 to 6 times per at least within the first month, then later on the follow-up can be increased. So the logistic and the conveyance is very high, especially in all the kind of settings, because patient have to come back again and again. So ultimately the cost might be most of the time much higher than the phaco surgery. So to consider the history, from the history, non-ocular history, should take a good non-ocular history. Sometimes we forget the non-ocular history many times. So it should be considered the assessment of the general health of the patients, and any risk factor for surgery that should be corrected before going to surgery, like some high-risk like patients on anticoagulant therapy, or the patient is very systemically ill, terminally ill patient. So in this type of patient, no need for going to surgery. So, and the high blood pressure, anticoagulant, antiplatelet should be managed accordingly. The anticoagulant, antiplatelet therapy should be stopped at least 1 week prior to the surgery in consultation with the treating physician. So in the history, the prior ocular inflammation or infection, history of prior ocular procedure, intraocular pressure range is also important, history of any bleeding disorders or consuming anticoagulant medications or any antiplatelet therapy, and history of any ocular trauma should be taken. So the patient can, or we can think about will my medication affect the outcome of the procedure? As we know, most of the patients were already on multiple medication for the long time. The conjunctival scarring process or inflammation has already started, especially in patient with the preservatives. So the preservative-free medications have minimal effect as per the studies shown that, but the maximum effect will be less if the patient were already on maximum multiple number of medications. So this should be keep in mind. Some surgeons prefer to reduce the number of medications, start oral medication, and some surgeons will start steroid with at least 1 week prior to the surgery. So the vision acuity is important. The success of trap does not mean just reducing the IOP. So the patient also to get at least maintain the vision acuity. So patient can ask the question, will I get the vision? So it asks the patient, will understand the patient that we won't get visual gain, but we're trying to preserve the vision patient already had. So there can be high chance for wipeout also sometimes. So these factors should be documented, and the best corrected vision acuity should be documented preoperatively. Of course, the lid hygiene and blepharitis, sometimes the patient can have this kind of picture with maybe due to medication or other causes. These kind of things has to be cleared before planning for the surgery. And the conjunctival scarring, this can be happen, maybe like previous surgeries or the bad ocular surface, And the last picture, the picture on the right side show we missed actually the history of SICH. Sometimes the small incision cataract surgery, the conjunctival scar may not be visible much high, very little scar, but this once open the eye, there is even a steel suture also within the scleral flap, on the scleral flap made for small incision cataract surgery. So these are the sometimes difficult on the table. This should be thoroughly evaluated before the surgery. The scleral thinning, of course, have difficult to go ahead with the trap, especially in the superior side, the site of the scleral thinning, and the cause for the scleral thinning also to be evaluated. And of course, the IOP, the intraocular, at the current IOP, the patients, because if the patient is, the IOP is very much high, then you have to reduce with mannitol or intraoperative other before oral acetazolamide, because the high IOP and sudden decompression can some devastating complications. So the IOP should be reduced as much, if possible, with mannitol or systemic oral medications. So gonioscopy, of course, have to perform to rule out especially the high chance for failure like NVA, maybe extensive synechia, and these things to be ruled out before planning for surgery. This is also part of the workup. The prior ocular surgery, especially those patients, sometimes now my vitreoretinal surgery is also called microvitreoretinal surgery. So sometimes there won't be much scar, just they are using 25 gauge or 27 gauge pod. There won't be much scarring, much scarring. So you can think about surgery, but if the patient had past history of vitrectomy, you will have a difficult time on the table. Once you enter the, once you enter into the eye, the chamber will collapse. The sclera will have a tendency to collapse. Even if you fill with the anterior chamber with viscoelastic, still there is a tendency of the sclera to be collapsed. So this difficult time will have difficult timetable. Of course, the scleral buckle patient should be thoroughly look for any scleral buckle history of any other kind of intraocular surgeries. So of course, once you have to lower the intraocular inflammation in the form of uveitis or maybe posterior or intermediate or anterior uveitis, the eye should be quiet for at least 3 months. If you don't have that kind of window, then you should start with oral steroid. Maybe you can, sometime our uveitis colleague will advise to strap along with the perioperative IV methylpred also, especially in kind of Bechet and very aggressive kind of, or in VKH kind of uveitis cases. So then the disease severity, that's also very important, how much the patient had the optic disc cupping and the visual field. If the visual field is involved in the center, it's very much near to the center, there can have a high chance for the wipeout. This should be explained about the patient, and also the surgeon should take out all the precautions during the surgery, like does not allow the eye to be in the hypotonic stage as much as possible. Frequent filling of the viscoelastic in this during the procedure also, and maybe with viscoelastic or air bubble, and very quick action on the table. Of course, the prognostication, one should establish the proper diagnosis and the severity of the cases, like primary cases or secondary cases, and what are the high risk cases for failure of the surgery. These should be kept before going for surgery, like post-PK, like a patient has already multiple surgery, or a phakic patient have high chance for failure and maybe vitreous prolapse, and is the patient have NV eyes. These kind of patients have high chance for the failure of the surgery. These all factors are determinable for the failure of the surgery. So these factors should be keep in mind once we need a thorough workup, and the diagnostic and prognostication also important, and documentation of course important before going for the surgery. So to conclude, planning should start weeks or months before surgery. Patient general condition and overall ocular condition prognostication should be done considered. Socioeconomic factors should not forget, and detailed ocular, non-ocular history including systemic and ocular medication should be considered. Of course, detailed examination of the ocular examination, diagnosis and prognostication of the case important before going into the patient and taken into the operation theater. Thank you.